Thank you. It is a pleasure to be here today and to talk about smoking cessation and the good news and the bad news of kind of what's out there. We are now talking about, I work in the field of addiction, and we're now talking about the opioid epidemic. But I want to remind us that actually we have the greatest epidemic, which is smoking epidemic in the United States. The smoking epidemic, when we think about it, it is a 20th century disease. Smoking was really uncommon at the turn of the 20th century, so 1900, very little smoking, and really it was industry that drove the great increase in smoking consumption. The tobacco industry developed the cigarettes, which were rolled cigarettes, easily packaged, systematically made, and we had this incredible increase in smoking consumption across the past century. And when we look at lung cancer deaths, these graphs really parallel each other. So again, when I think of smoking and the smoking-related diseases, lung cancer is really the primary one that we think about. The good news is that even though we knew that smoking had tremendous health-related effects, starting with the first Surgeon General report in 1964, it took us about 20 years before we started to bend the curve with the amount of cigarettes that we consumed. That was driven by really the public health campaigns that we had, indoor clean smoking, and then the taxation that came through. But with that, we've had this tremendous decrease, and now we're starting to see this decrease in lung cancer that's paralleling it. So smoking is also a worldwide problem. Even though in the United States we've seen this change, worldwide smoking is continuing to increase, in particular in the third world countries. Over 1 billion people smoke in the world. 10 million cigarettes are consumed per minute in the United States, and there are over 5 million deaths per year related to smoking. And in the United States, when we're talking about the opioid epidemic, we're horrified that we have 60,000 deaths per year related to opioid overdoses. It's over 400,000 deaths that we have that are related to cigarette smoking. So historically, it has been 1 in 2 cigarette smokers had died from their smoking. And our goal really is to prevent these deaths. So I view the lung cancer is actually one of our failures in prevention. So I just want to kind of give a quick call out to the majority of my work actually is looking at the underlying neuroscience behind addiction. So addiction is an addictive component that is really driven by what's happening in the brain. And there are 2 main components with it. We have variation in our nicotinic receptors. So how we, when we smoke, we're essentially dosing ourselves and dosing our nicotinic receptors. The chromosome 15, alpha 5, alpha 3, beta 4 nicotinic receptors, there's variation in them, and that is that variation drives smoking behavior. And those underlying genetic variants are also the strongest genetic variants that predict lung cancer. So really when we talk about the genetics underlying lung cancer, the strongest component to that is the genetics underlying smoking behavior. The second aspect has to do with nicotine metabolism. How an individual metabolizes nicotine is the other main component. So really, smoking is a pharmacologic, pharmacogenetic aspect that individuals are doing. So with that viewpoint, it really, I want you to kind of change thinking. We have to change the thinking of the public of it just being a bad habit that we have. It's not a bad habit. Well, it is a bad habit, but it's biologically driven. So I'm going to just go through 3 levels that we should be thinking about when we talk about eliminating smoking. And I want everyone in this audience to really think about what they could do for these 3 levels, at the public health level, at the systems level, and at the individual provider level. So with the public health level, we really have great news going on. the great news is that the prevalence of smoking in the United States is at its lowest level. It's 15% of the population. This is a drop from 2005 when it was 20%. So we're having this continuing, ongoing decrease in smoking in the United States. Great news. The issues that we have to struggle with is this great news is not evenly spread through the country. In the Midwest, where I come from, kind of the Mississippi Delta region, we think about smoking as really a main problem, and we have about 25% of the population continues to smoke. California and Utah are the model areas where their smoking prevalence is less than 10%. But I anticipate that the smoking of combustible cigarettes is going to continue to decrease. But how could we continue it more quickly, and how could we hit the regions that are really still struggling with tobacco use? So one of the areas that I want you to all be aware about is that there's this public health campaign going on that's Tobacco 21, and the goal is to increase the age of purchase for tobacco products to 21. We know that if we delay any type of initiation of a substance, we decrease addiction. So a couple states have made this a statewide policy, Oregon, California, and then Maine, Hawaii, a few others. Other states are doing it at a local basis, cities and counties. So if you hear about Tobacco 21 coming to your area, please go and testify. Testify in front of your city officials, your county officials. Really moving this age of the purchase of tobacco products to 21 will be one of the greatest public health campaigns in prevention of disease that we could have. So looking at a systems level, working in a healthcare system is really quite complex, and this has been the last few years. My work has been, how do we implement the smoking cessation that we know effectively across our system? So for meaningful use and CMS regulations, we think about smoking as the fifth vital sign. And so smoking should be documented in every patient health record. It should be updated regularly, and we should indicate the changes. There's two simple questions that should be asked. Have you smoked cigarettes in the past month? If you're a past month smoker, you're considered a current smoker. And how many cigarettes do you smoke per day? So as my work has been moving into implementation, I must say I've been really shocked at what I've been seeing about healthcare systems and what we do even at my own institution. So one thing is I generally think this is a question that should be answered across all different levels: medical assistants, nursing, and physicians. And though I find physicians generally have ease with this question, just think of this as this is just a question that you ask everyone. There's a tremendous amount of resistance at the medical assistance level of asking this question. And this resistance is because there's this discomfort, feeling that you're confrontational when you ask this question. And there's this kind of thought of that there's shaming involved. So what's been happening in many medical systems is the question is asked once and then is just fed through as we have electronic medical records. So, the medical record could just continue moving it forward. So I have tremendous concerns that this may be a mismeasurement that we have in the electronic medical record. And I want you to go back and talk to, staff, nursing staff, MAs, about how important this question is asked. We've done focus groups with our patients in our healthcare system, because when we've heard about this discomfort from the medical assistants and the nursing, we wanted, their concern was that the patients would be upset with them. And what we hear again and again from patients is, well, yeah, I feel like you're asking me. When I'm in the hospital, I get asked 15 times, but I think you're doing it just as a checkbox. You're not doing it to really do anything for me and to get smoking cessation, and that is a missed opportunity. So I want you to push and make sure you know what's happening in your institution, who is asking the question, because oftentimes it's not the physician necessarily asking the question, because we've tried to relieve the physician duties to their, so that physicians could move at their highest level of expertise. But I think what we've done is we've missed this type of training and comfort with our medical assistants and nurses at times. So brief counseling works. There's 2 phrases that I want you to leave with. And I want you to bring this back to the other healthcare providers you work with. Quitting smoking is one of the most important things you could do for your health. This is the phrase that could be used again and again, and this is an important message for our patients. And the second message is, it's never too late to stop smoking. So the other issue that we frequently hear of resistance, both at the medical assistant and the nursing level, is, well, they have cancer now. Isn't it too late? Oh, they have emphysema. Oh, they have these things. Really, do we want to bother them now about this? There's too much stress involved. So the data are very clear. There are health benefits to smoking cessation at all points in your life cycle. So even after a diagnosis of cancer, regardless of the stage, regardless of the prognosis, there is an improvement in outcomes, there's a better tolerance of treatments, there's a reduced disease recurrence, reduced secondary cancers. So it's never too late to quit smoking. And that is the message that we have to continuously give. So thinking about it at the pharmacologic level, medications work. The 2 medications that are most effective are combination nicotine replacement therapy. So that means at 2 types of nicotine replacement therapy. You could do a patch and then a short-acting nicotine, lozenge, gum, inhaler. And varenicline is the second most effective. So those 2 hand in hand really work quite well. What we know is counseling works. There's a dose effective counseling. So even though these very brief interventions, these very brief phrases work, more counseling works even better. What we know is medications work, counseling works, both are best. And then one of the issues that we have is we often don't have the resources for any type of counseling in systems. And what the government has done is it has developed these national quit lines. So run through states, run through the NCI, and also run through the CDC. So 1-800-QUIT now. And those are opportunities for our patients who are continuing to smoke to get counseling. So there really is hope. All of these things do improve smoking cessation. So we should not have this fatalistic view that, people are just going to continue to smoke. So as I said, the combination nicotine replacement therapy and the varenicline are the top line treatments. Second line treatments could be a single replacement therapy. It's not quite as effective, but if you're concerned about too much nicotine replacement, bupropion, another medication, is a second line treatment. Also, it's an antidepressant medication. And then the behavioral therapy could be through a variety of different ways. Individual, groups, internet. There's more and more different types of internet apps, texting, phones, quit lines. So connect our patients to these different aspects, and that is really key. So I want to end on the controversy that we have with electronic cigarettes. So 10 years ago, we really didn't see electronic cigarettes. This editorial from the New York Times in 2013 was starting to kind of question What is it good? Is it bad? And I will say that there's remains controversy about electronic cigarettes. Electronic cigarettes have the potential to be one of the best public health changes in the United States. So how could that be? If we convert everyone who is smoking a combustible cigarette to an electronic cigarette today, we will reduce many lives. The concern we have is, are we going to develop a new group of smokers with teenagers? Are we kind of starting this cycle all over again? And we're really in this point where we're not quite sure what's going to happen. So what are electronic cigarettes? Oftentimes that they're called ENDS, also electronic nicotine delivery systems. They're called that because though the first generation of these looked like electronic cigarettes, these are now becoming more and more complex. They're these big things. Sometimes I think it looks like someone is walking down the street playing a clarinet because these are getting so large. And they're becoming more and more common. So what do we know? We know that these electronic delivery systems are not FDA-approved smoking cessation devices. Okay? There's not enough data at this point to support the use of e-cigs in smoking cessation alone or in combination. So I'm going to say the data don't exist. It's not that they're negative, but it's the data do not exist. There's insufficient evidence regarding its safety and efficacy. But this, I think, is really the important message here, which is even though we don't know about enough about these electronic cigarettes and nicotine delivery systems, what we do know is that combustible cigarettes are very dangerous, kill people, and their adverse effects are not in question. So we have to get our patients off of combustible cigarettes. And so the controversy around is how much do we move them towards a harm reduction strategy? Our goal should be to move our patients to the most effective smoking cessation methods, that is with the known medications, the known counseling. But the key thing is make sure our patients know the dangers of combustible cigarettes. So as we're moving in our scientific, rigorous way, I will say the US public is doing its own experiment. So we're looking at e-cigarette usage in the United States. It is increasing. And this paper just came out from the British Medical Journal this summer, and I think is giving us a hint about where it is going. So these, the graphs are on the top is the quit rate per year, quit attempt rate per year. So it's the idea of how often people are trying to quit if you're a current smoker. So with current smokers, half of them are trying to quit every year. And this quit rate has remained pretty constant for really decades, at about 40% are trying to quit every year. What we noticed is in this past release of this tobacco survey, which is done through the census, this is a large survey, and what we saw was this increase in quit attempts in 2015. So the bar goes along, and then you have this increase. And it divided up the 2014, 2015, those are the white bars. The white bar on the left is people who've never used an electronic cigarette. The white bar on the right is those who have used. So we know that the people who are using electronic cigarettes are actually trying to quit. The other thing, which is amazing, is on the bottom is successful smoking cessation. So only about a little over 4% of current smokers successfully quit per year. Again, in 2015, we saw the first bump we've seen in decades. And this bump was among the people who were using electronic cigarettes. So This is just population-based data, putting it out there. This experiment is going on. We'll really see what happens in the long run. But I will say that around the world, there are different approaches, and the UK is really pushing electronic cigarettes as a harm reduction strategy. So it remains controversial what we should do, but I think the end point is that we could attack smoking cessation at multiple levels. At the public health level with policy, Tobacco 21, at our systems level, make sure it's being done, and then at our individual patient level. So let's make the world a smoke-free world. Thanks.